Hello everyone. So NEET PG 2023 done. Now we are here for INI-CET 2023. Yes, something extra you need to read in that. Some extra edge. Yes, I am here to help you. Yes, today we are covering pediatric cardiology MCQs. Yes, something in a different manner for INI-CET. Now Selection का संकल्प. Yes, flat 20% off on medical subscription, valid till 31st March. Go for it, my friends. Go for it. 100 plus learner successfully cracked NEET PG. What else you want? Dr. Rupesh, Akar, Rohit, Rajesh, Pragati, Deepak. You may be next with your pick. Yes, it's an honor. It's a proud moment. Okay, so you may be next. Enroll on an academy. Yes, now you can aim next or NEET PG. Yes, this is the batch. Start from 28th March. We will cover everything in slowly and slowly. Total duration 9 months. You get everything to boost your preparation. Trust on Unacademy and its team. Enroll in this now. Mission INI-CET high yield revision batch. All the educators and last mile preparation with Dr. Janab. Name need no introduction. These all are there for you on Unacademy. Yes, today we are here to cover our cardiology MCQ. So just answer this question. Yes, we are preparing for INI-CET. So which of the following is or are diastolic murmur? You know, astringent murmur present in aortic regurgitation. Carriacou murmur present in rheumatic fever. It's a murmur of rheumatic valvulitis. Still murmur. It's a functional murmur. Present in severe anemia, thin baby. Gibson murmur. Yes, anybody? Where is the Gibson murmur? Gibson murmur present in PDA. And Dox murmur. Dox D. It is LAD stenosis. Yes, you know all these murmur, but this is not going to solve our question. Question is, which of the following is diastolic murmur? Which of the following is diastolic murmur? Astringent murmur is diastolic. Carriacou murmur is again diastolic. Functional murmur, it's a systolic murmur. PDA, no need. It's a continuous murmur. And Dox murmur, again, it's a diastolic murmur. So it gives you a easy thing, or what you can say. Fourth, Gibson, you know, it's a continuous murmur. So whatever the fourth choice should not be there. Okay. Now, astringent 1, Carriacou 2, and Dox murmur 5. Where is 1 to 5 is written? 1 to 5 written in C. So this is, my friend, INI-CET for you. Multiple choice answer. Something different. Yes, Subha, it's 1 to 5. Very good. Very good. Very good. So you should remember murmur with name. Yes, INI-CET. Long history based question. Multiple choice question. You may find one word question. So this is the classical question of INI-CET. Astringent murmur present in aortic regurgitation. Roser murmur, it's present in VSD. Carriacou murmur in rheumatic fever. Dox murmur, it's present in LAD stenosis. Gibson murmur, it present in PDA. Gram steel murmur present in PR plus PH, hypertensive PR. Still murmur, it's a functional murmur. And ratidinous murmur present in complete heart block. Easy to remember. Easy still is a systolic. Gibson is a continuous. Rest all are diastolic murmur. Rest all are diastolic murmur. So yes, you need to remember, yes, you are going for a competitive exam, INI-CET, and you should know the type of murmur, systolic, diastolic, continuous with their name. Answer this question. An irritable 12-month male, 1 week history of high fever, rash, examination reveal bulbar conjunctivitis, cracked lip, cervical lymphadenopathy. What is this? Yes, Subha, what is this condition? Is anyone? What is this? High fever, rash, conjunctivitis, cracked lip, adenopathy. What is this? Yes, it is KD. What is KD? Kawasaki disease. Kawasaki disease, in which fever more than 5 days duration. Fever more than 5 days duration. If a child comes to you with fever with more than 5 days and you find no cause for fever, and you identify no cause for fever, child having no URI, no UTI, it's not malaria, it's not typhoid, it's not dengue, all test negative, fever since 4-5 days, then you search for other criteria. Presence of 4 out of 5 criteria, if you find 4, this need to be labeled Kawasaki disease. What are those 5 criteria? Changes in the extremity. You find edema of palm and sole, peeling of skin, which is present in 2nd week. Then rash, polymorphic rash, bilateral non-purulent conjunctivitis. Conjunctivitis is there, but that is non-purulent conjunctivitis. Cracked lip, strawberry tongue, so prominent. Show me your tongue. When child show the tongue, you find it's a strawberry pink tongue. Unilateral cervical lymphadenopathy. Conjunctivitis is non-purulent. Eyelids are not sticky. They are red but non-purulent. So you find 4 out of these 5, make the diagnosis Kawasaki disease. Yes, Kawasaki disease. It's a diagnosis of intelligent pediatricians. Yes, see, conjunctivitis, cracked lip, strawberry tongue. See the tongue, you never miss pink strawberry tongue, edema of the hand, edema of the sole, and peeling of skin. Peeling of skin. So you find rash, conjunctivitis, strawberry tongue, cracked lip, edema of the palm and sole with fever where no cause. You promptly make the diagnosis of Kawasaki. Now, you may be wondering why I am saying you need to make promptly diagnosis of Kawasaki disease. What happened in Kawasaki disease? In Kawasaki disease, there is coronaries involvement. What do you mean by this? In Kawasaki disease, 25% cases coronary get involved. What do you mean by coronary get involved? This is aortic wall, which give origin to left and right coronary artery. If patient is having Kawasaki disease, this is normal. What happened? The coronaries arises is going to be dilate. Aneurysmal dilatation of the coronaries. Coronaries dilatation is there. So it occur in 25% cases. Once, why I am telling you need to diagnose Kawasaki very promptly, because delay will lead to more chance of coronary involvement. If you diagnose this early and time, so you can start IVIGG. If you start immunoglobulin, chance of coronary involvement is less than 2%. Once you start IVIGG, fever subside within 24 hours, inflammation subside, no risk of coronary involvement. But if you are missed the diagnosis, it's happened in the periphery, child is having fever, rash, they make it measles or something else, they start antibiotic and some anti-allergic things, but fever continue. But after 2 weeks it subside. Unfortunately, that was Kawasaki. Then child presented to you sometime with chest pain, sometime with sudden death, because that time Kawasaki that was missed. Kawasaki that was missed now presented with coronary dilatation. So if you find this typical history of fever for 7 days, cracked lip, strawberry tongue, non-purulent conjunctivitis, unitus cervical lymphadenopathy, make the diagnosis of Kawasaki and start immunoglobulins. Yes, role of aspirin is there once coronary involved, coronary dilated. If coronary is maybe get normal in 3 months, 6 months, 9 months, 1 year, or maybe later. Till coronaries are not normal, you put the child on aspirin. Aspirin. So there are many patients in my follow-up, being a pediatric cardiologist, who are on aspirin for months. Yes, we do the echo with 2 month or 3 monthly and see the coronary. If they remain dilated, we continue aspirin. We continue aspirin. No steroid. Immunoglobulin is the drug of choice for Kawasaki disease, and it's a classical question. Answer. Cyanotic heart disease with increased pulmonary blood flow are. Try. So you all know cyanotic heart disease is of two types. Increase pulmonary blood flow and decrease pulmonary blood flow. So what are the feature of increased pulmonary blood flow? How can we identify this patient is having cyanotic CHT, increased pulmonary blood flow? There is a recurrent respiratory tract infection, interrupted feeding, fast breathing, fast respiration. It means child is cyanosis but having interrupted feeding. When he feed, he give up the nipple in a few seconds. Interrupted feeding, fast respiration. It means cyanosis but increased pulmonary blood flow. When we say it's a decreased pulmonary blood flow, when mother give a classical history, cyanosis increase when child cry. There is the history of cyanotic spell. So grossly, at least we should remember, when cyanotic CHT increase pulmonary blood flow, three things should come in our mind. It can be TGA, it can be TAPVC, or it can be truncus. Increase pulmonary blood flow. Three things. Only one you can diagnose with auscultation confidently, that is TAPVC, in which second heart sound wide and fixed split. If cyanotic CHD with decreased pulmonary blood flow, there are 6 conditions of Fallot physiology, but generally you need to differentiate whether it's TOF or it's tricuspid atresia. Question will come. We can differentiate in this, but this is the question. Cyanotic CHD increased pulmonary blood flow, TGA, TAPVC, truncus. Cyanotic CHD decreased pulmonary blood flow, TOF and tricuspid atresia. There are many DORV, VSDPS, single ventricle PS, Epstein, but you need to remember 2 only for MCQs. Now come to our question. Increased pulmonary blood flow. Definitely it's not TOF. TGA is there. It's not tricuspid atresia. Truncus is there. TAPVC is there. So our answer will be 2, 4 and 5. 2, 4 and 5. 2, 4 and 5. Don't worry about PDF. Shubham, I will give you on my group. I will share. Okay. Just concentrate. 2, 4, and 5. Subha, very good. So, yes, I start with basic. Then I will cover all these CHDs today in the today's class. See, it's clear? Increase flow, decrease flow. Answer this question. 30 seconds I will wait. Give you the chance. Try. 18-month-old child presented with recurrent attack of cyanotic spell. Means it's a cyanotic CHT. Child present with recurrent attack of cyanotic spell. It means you are dealing with decreased pulmonary blood flow physiology. Clear? So there is a history of squatting, dyspnea on exertion, ECG show RVH. Which of the following is the expected finding? Let's see. Let's see. So just clear your basic. It will take just 2 minutes. I give you the nice basic of this thing. So cyanotic CHD decrease pulmonary blood flow. So most likely it's a TOF. So what are the 4 component of TOF? This is LA, this is LV, this is RA, this is RV. RV give origin to pulmonary artery where there is a stenosis. There is a VSD, there is overriding of aorta. And last one, there is RVH. So what are the 4 component of TOF? Number 1, RV, right ventricular outflow tract obstruction. RVOTO, right ventricular outflow tract obstruction. Here it is seen. Then number 2, there is VSD. Number 3, overriding aorta. Try to understand. Normally, aorta committed to LV. So blood from LV goes to aorta. But here you can very well see blood from RV and LV both can go to the aorta. LV and RV overriding aorta. And fourth is right ventricular hypertrophy. Slowly and slowly. So what happened in TOF? What are the 4 component of TOF? RVOTO, VSD, overriding aorta and RVH. Now concentrate. Blood from LV. It's a pure blood. Goes to body. Blood from RV has 2 exit. It can go into aorta. It can go into lungs also. But there is RVOTO. So less blood goes to pulmonary artery. That's why it's the example of decrease pulmonary blood flow. Decrease pulmonary blood flow. So most of the blood via overriding aorta goes to body. So body received mixed blood. So what happened in body? There is cyanosis. When there is a cyanosis, there is clubbing. When cyanosis is there, they are bound to have polycythemia. Eyes are red. So cyanosis, clubbing, polycythemia. Now mother complain. My child become more blue when child is crying. So there is a history of cyanotic spell. Then mother will tell you, sir, when my child squat, sit in the toilet position, cyanosis relieved, dyspnea relieved. So there is a history of squatting position. So 5 features of TOF. There is a cyanosis, there is clubbing, there is polycythemia, there is a cyanotic spell, there is a history of squatting position. Squatting position. Clear? Now see, less blood goes to the lung. So pulmonary blood flow is decrease. When pulmonary blood flow decrease, chest X-ray become oligemic. Black lung fields, oligemic lung fields, black lung fields. If pulmonary blood flow is increased, chest X-ray would be plethoric, but here it's oligemic lung field. Okay, when less blood reaches to lung, so what happen? Recurrent respiratory tract infection never occur in TOF. Less blood goes to the lung, CHF not occur in TOF. Then cardiomegaly not occur in TOF. Make it simple. What are the 4 components of TOF? RVOTO, VSD, overriding aorta, RVH. What are the 5 features of TOF? Cyanosis, clubbing, polycythemia, cyanotic spell, squatting position. What is the X-ray in the TOF? Oligemic lung field with boot-shaped heart. Never occur in TOF. Recurrent respiratory tract infection, CHF and cardiomegaly not occur in TOF. Am I clear? Now come to the question. TOF, polycythemia is there. Cardiomegaly not there. CHF not there. Oligemic lung field is there. So answer would be 1 and 4th. 1 and 4th as usual. Suba SP is right. D is the correct answer. So first try to build up your concept in TOF. Then come to the question. Typical INI-CET question. Clear? Multiple choices. Clear? 1 and 4th, what occur in this physiology patient? Fallet physiology patient. Tetralogy of Fallet, polycythemia and oligemic lung field. Polycythemia and oligemic lung field. Am I clear? Answer this question. Read. I wait for 30 seconds, 40 seconds. You read and make your answer. Three-month old infant present in pediatric emergency, complain of respiratory distress, means respiratory rate is fast, born at 30 week of gestation without any complication, noted bluish discoloration of nails and lip, means it's a cyanotic, complain of interrupted feeding, not gaining weight. Interrupted feeding, respiratory distress, not gaining weight. So it is cyanotic CHT with increased pulmonary blood flow. Cyanotic, heart rate 140, respiratory rate 56, mild subcostal retraction. Now come the key point. Has wide and fixed splitting of second heart sound. So if in the question you find wide and fixed splitting of second heart sound and child is cyanotic, it is TAPVC. If child is acyanotic, then it has to be AST. It is simple. So cyanotic CHD, finding of increased pulmonary blood flow plus second heart sound, wide and fixed split. Only one answer in this universe. Cyanotic CHD increase pulmonary blood flow. Second ultrasound wide and fixed plate, it is TAPVC, total anomalous pulmonary venous connection. Clear? Now, there are so many questions. There are so many questions. It will take 1 minute. You know all these things, but it take just 1 minute, which cover the previous year question of INI-CET also. This is LA, LV, RA, RV. From LV, aorta arise, take blood to the body. From body, blood comes through SVC and IVC into RA. From RV, pulmonary artery arise, which take bloods to the lung. From lung, the blood comes into LA. Now concentrate here. This is the pure blood from lung. Come into LA, LV, aorta, body receive pure blood. In body, blood get deoxygenated. So impure blood through body, SVC and IVC reaches to RA, RV via pulmonary artery goes into lung for oxygenation. Now concentrate, concentrate, concentrate. Concentrate, my friend, concentrate. This is LA, LV, RA, RV. From LV, aorta arise, take blood to the body. From body, impure blood reaches to RA. This we know. From RV, pulmonary artery arise, which take blood to the lung. Now here the game start. From lung, pulmonary vein supposed to join where? Pulmonary vein supposed to join LA. But here all four pulmonary vein unite anomously and drain into RA. So what happened in RA? Pure blood and impure blood both comes into RA. RA receive pure and impure both blood. So this whole blood, pure and impure, goes to lungs. So normally only impure blood goes to the lung. So that's why pulmonary blood flow is increased. Why there is a cyanosis? It's a rule. Whenever there is a TAPVC, there is always a small ASD or PFO is there. Through this mixed blood goes to body. Mixed blood goes to body. So body receive mixed blood. There is cyanosis. And pulmonary blood flow is increased. Cyanotic CHT, increased pulmonary blood flow. TAPVC, total anomalous pulmonary venous connection. So last to last INI-CET question, 1 year back. Which of the following heart disease saturation equal in all four chambers? See the diagram. Same blood comes to RA, same blood goes to RV, same blood goes to LA, and same blood comes to LV. So all four chamber saturation is equal. All four chambers SpO2 equal. This is occurring TAPVC. This was last year INI-CET question. All four chamber, because logic is there na. You can see the blood which reaching to RA is going to LA, same blood going to LV, and same blood going to RV. So all four chamber saturation equal. And this classical figure of 8 or snowman appearance. so many times. This is the classical X-ray finding of supracardiac, which is the commonest type of TAPVC, supracardiac TAPVC. Am I clear? Just remember this image, this physiology, all four chamber SpO2 equal, and this is the classical question on TAPVC. Am I clear? Clear? Answer this question. Answer. So cyanotic newborn, it's a cyanotic congenital heart disease, left ventricular impulse, 3 by 6 ejection systolic murmur, X-ray shows oligemic lung field. Hold on. So our question, it is cyanotic CHT because X-ray showing oligemic lung field. So cyanotic CHT with decreased pulmonary blood flow. Cyanotic CHT with decreased pulmonary blood flow. Clear? Now we have two options. Either it is TOF or it is tricuspid atresia. Either it is TOF or it is tricuspid atresia. Now see, this is normal finding. Blood from SVC and IVC come to RA, RV. But what happened in tricuspid atresia? Impure blood from SVC and IVC comes into RA. Look at the tricuspid wall. It is atretic. Atretic. So this blood is not supposed to go into RV. When blood is not going into RV, so RV is not developed. So there is hypoplastic RV. Hypoplastic RV. Whole blood is going to the through ASD into LV, and through VSD it again goes into lungs. So tricuspid atresia, it's a rule, RV is hypoplastic and main ventricle is LV only. But what happened in TOF? TOF, there is always RVH, right ventricular hypertrophy, and ECG show right axis deviation. But cyanotic CHD decrease pulmonary blood flow if you find mainly LV forces. Mainly LV forces, LV impulse, LV forces, and ECG show left axis deviation, then it is tricuspid atresia. So our question, it's a cyanotic. Oligemic lung field, decreased pulmonary blood flow. ECG show left axis deviation, left ventricular dominance, increased left ventricular impulse. I can say this question is so common, so easy, it expire, it's not comes. But now it's a classical question in CHD whenever we talk about cyanotic CHD. It's a cyanotic CHD, decreased pulmonary blood flow, LV forces, it has to be tricuspid atresia. Am I clear? Clear? If clear, please give me a thumbs up. Clear? It's not TOF because TOF having RVH and right axis deviation. Tricuspid atresia, LV forces, left axis deviation. Clear? So this is cardiology session. Tomorrow, same time, we have neurology session. There are many questions on cardiology still left. We will cover a series. So these are the few cardiology questions. Now we do few neurology questions. Tomorrow, same time at 5 p.m. Classical. Just sit for half an hour. You see good classical neurology questions. Pediatric neurology. Like today cardiology, we started with murmur, all are diastolic murmur, then Kawasaki disease. Then we go to Cyanotic CHT, decreased flow, increased flow, then classical question on TOF, classical question on tricuspid atresia, classical question on TAPVC. Tomorrow we will cover neurology. Hold on. I have a class just now. After 25 minutes, it's a free special class, 6 p.m. to 7 p.m. You can watch, anybody can watch. It's a free special class on Unacademy app. Aim next NEET PG, must know topic and MCQ. I cover some good MCQ just after 25 minutes. So be there, be there in this class. You will be definitely benefited. We cover some concept of nephrotic syndrome, some other good topics, some more cardiology questions. So you will be good to know all these things. Just a brush up or revision or something new will be there for you. So just we will meet after 25 minutes for this session today and tomorrow. Pediatric neurology questions, pediatrics neurology questions. Till then, bye bye. Hope to see you all on Unacademy app for this session after 20-25 minutes. Come with your queries, your expectation. You can put your comment in special class. Sir, we want some more classes like this. Questions on pediatric hematology, question on pediatric nephrology, question on pediatrics endocrinology, which is good for INI-CET. So yes, this is the first class. So many new learner are there. So just guide me what you want, what your expectation. I am there for you people. Thank you. Bye bye. Hope to see you all after 20-25 minutes here. Thank you. Hmm. Go.